Gentlemen, dear Krish, thanks for inviting me to come here. It's always a pleasure to come to Chennai. And for this little teaser, I decided to present cases because that's what I'm most interested in doing research into psychiatry and neurology. I always thought that the cases are the most fascinating aspects of my and our work. And for that reason, I thought I present two cases to you. Neuropsychiatry is, of course, a broad theme, and you do have psychiatric presentations in many, many different neurological contexts, not only autoimmunity, but also in epilepsy, rheumatology, Parkinson's syndromes, genetic disorders, vascular disorders, whatever. But today I want to talk about, I want to present to you two cases with autoimmune disorders who turned out to have autoimmune disorders, and the sometimes rather long way to get to that insight. And the whole story began with this paper, the story of the autoimmune encephalitis. So the insight that psychiatric presentations may be caused by immunological diseases really started in 2008 with the discovery of the anti-NMDA receptor encephalitis. And this is the first lady we discovered or found in 2009, my first patient with the NMDA receptor encephalitis. She was a 31-year-old patient who until that age, so for 3 decades of her life, was perfectly fit and well, no history of psychiatric disorders whatsoever in the family. But then suddenly, out of the blue, she was working in a big company as the secretary to the big boss, and so she had a very high functional level. And then suddenly, within weeks, she developed hallucinations, delusions, paranoid ideas, and all began with a set of 3 seizures. So that was why at the very beginning everybody thought that must be something neurological, and so she was sent to a university department for neurology, where she was diagnosed based on the high level of a university hospital, and they didn't find anything. So they referred her back, and they said this is not neurological. And to give you an idea of what it looked like, I have brought you these 2 videos. And after that, she was treated for 2 years in different psychiatric hospitals in South Germany under the diagnosis of catatonic schizophrenia. And here below you see another. This is of course in German, but I have translated it to you like the other videos.
Schauen Sie mal zum Dr. Perloff. Arm heben. Linken Arm jetzt bitte heben. Hochheben. Gut. Ganz hochheben. Den linken Arm. Und jetzt locker fallen lassen einfach.
So what you see here are catatonic features. The doctor tells her to lift the arm, and then he tells her to let go, but the arm gets stuck in the air. It's a phenomenon called catalepsia, and it's one of the earliest symptoms of catatonia or catatonic schizophrenia. That's the way it was named at that time. And here you see how she moves the hand to the mouth, but then the hand gets stuck, and she kind of forgets to take it away, and she freezes. So one of the very, very classical catatonic features. Now, in these 2 years in different psychiatric hospitals, remember, she had been investigated in the university neurological department, and they said there's nothing wrong with her neurologically. She was then treated for 2 years in psychiatric hospitals with many, many different drugs, and I just want to give you an impression of how many drugs they were. Then eventually she was referred to our specialized department, and at that time, in that neurological hospital, they already knew about these autoimmune neurological disorders, about the NMDA receptor encephalitis. That's what she was suffering from. But at that time, it was not known that the test could be false negative. And when she came to us, I had heard that, and then I sent her CSF to Angela Vincent to Oxford, and she discovered that she was suffering from NMDA receptor encephalitis. And after that, we did all these investigations, including this PET imaging. And even though I don't expect you to be able to read PET images, even as a lay person, you can see, for example, if you look at this picture, that there is a strong difference between the right and left hemisphere in metabolizing glucose. And with the autoantibody finding and the PET image finding, it was clear that this lady was not suffering from catatonic schizophrenia, but from a neurological brain disease called anti-NMDR receptor encephalitis, a disease where autoantibodies in the body dock to brain structures and then in turn lead to dysfunction of the affected brain areas. You can see the dysfunction here, and you saw the clinical picture in the first movie. And then after immunotherapy, so after having learned that this is not catatonic schizophrenia, but rather NMDA receptor encephalitis, we treated this patient not with neuroleptics, but with immune therapy. And this is just, again in German of course, but just to give you an impression of what she looked like later.
Schon schriftlich niedergelegt, dass wir auch diese Aufzeichnung verwenden können für die Lehrzwecke oder für die Fortbildungszwecke.
Genau.
Okay. Ja, wie geht Ihnen denn jetzt mittlerweile?
Also mittlerweile ganz gut. Also es sind immer noch kleine Einschränkungen.
So I think I can stop it there. It was just to give you an impression that all these motoric symptoms were gone, and she was more or less healed. I mean, she did have some sensitivities to going to crowded places, whereas before suffering from this autoimmune encephalitis, she was loving to go to a vivid marketplace. Afterwards, she still didn't like it because it was too much, too loud, too many social signals for her. But apart from that, she was absolutely fit and well. Now, this is what I call a classical neuropsychiatric presentation, even though she had been diagnosed as suffering from schizophrenia. The whole story started with seizures, and that doesn't really belong to a classical primary psychiatric presentation. But there are also other cases, and that's the second case I want to present to you today, this evening. This is a lady in whom we too thought that it's rather primary psychiatric. A 42-year-old teacher and sport therapist. She had suffered from bouts of depression, age 22, 28, 32. Then age 35, she developed hallucinations, delusions, sexual delusions, and also delusional smells. And age 40, 41, and 42, she had acute exacerbations of these schizophreniform symptoms. All her thinking was sexualized, so she always had to think about different sexual meanings. And this is an example of what she looked like in this state.
Sind wir am nächsten Tag weggefahren. Und da hatte ich am Morgen schon den Eindruck, meine Mutter hat das irgendwie gemerkt. Also ich kam die Treppe runter und meine Mutter sagte so, na, Herrlein? Und so ist sie nie zu mir, was sagt die nie zu mir? Und ich war so, oh, da dachte ich, ja, okay, es muss damit zusammenhängen, was ja immer meine Fantasie war, dass andere das merken und so. Da dachte ich, ja, wir haben doch gar nicht viel gemacht, also ich meine, das war doch jetzt nicht.
Well, I can cut it short at that time. So she was slightly fast in her thinking. And the whole content of her thinking, I could have gone through that video for another 3 minutes, and you would have realized that the whole content of her thinking was sexualized, and she couldn't stop her from thinking that everything she was seeing, every mimic, every facial expression was somehow related to some strange sexual thoughts. Now, the investigations in this lady were rather normal. She had, in the MRI, findings a slight temporal lateral atrophy. The EEG was slightly abnormal but very diffuse. There was a diffuse rhythmic slowing, which you probably maybe you can see it from afar. And the CSF was basically normal apart from a blood-brain barrier dysfunction, but then again that you see in about 20% of people. And then we had her as an inpatient 3 times. She also had Hashimoto antibodies, and with having this signal in the laboratory finding, you know that there are very few cases who may respond to cortisone. But since everything in this case was so classical for schizophrenia, I thought, well, if I start treating this patient with cortisone, I can almost treat 20% of my patients with cortisone. But having tried out the last possible neuroleptic drug, clozapine, to which she responded but always got side effects, then after the third admission we tried cortisone and then see what happened.
Vielleicht können Sie einmal berichten, wie es Ihnen momentan geht.
Ja, also ich bin sehr erleichtert und sehr froh, dass jetzt die Stimmen weggegangen sind seit ein paar Tagen, die ja sehr hartnäckig irgendwie bei mir geblieben sind, trotz der Erhöhung des Solian. Ja.
Mal ganz kurz, wie lange liegt jetzt die Cortisonbehandlung zurück?
Die Cortisonbehandlung ist beendet worden vor 2 Wochen, also die Infusion.
Okay.
Ja, und ich habe jetzt wieder das Gefühl, dass das Gehirn so durchgepustet worden ist, dass es wie so eine Strukturveränderung des Gehirns ist dass ich dadurch auch diese ganzen Schemata im Gehirn wieder verloren habe. Diese Wahnschemata bezüglich der Sexualität, die sind jetzt im Moment wieder überhaupt gar nicht interessant, sondern die sind irgendwie komplett distanziert von mir. Also die interessieren mich überhaupt nicht mehr.
Wenn ich mich jetzt so kratze oder sowas mache?
Ja, das ist vollkommen uninteressant geworden.
Wie erklären Sie sich das?
Ja, es ist, als hätten die keinen Platz mehr in meinem Kopf, als wäre das irgendwie alles zu viel und als wären die auch vollkommen ohne Bedeutung.
Okay. Und haben Sie jetzt noch so diese Gerüche auch noch anders wahrgenommen in letzter Zeit, dass Sie sexualisierte Gerüche gerochen hätten?
So you can imagine that we were quite impressed by this rather unexpected experience after 3 years of trying all the neuroleptic drugs, the classical drugs for schizophrenia. We tried cortisone and within 2 weeks all the symptoms were gone, the hallucinations were gone, the delusions were gone. Half a year later she redeveloped the same symptoms, so we did another course of cortisone IV over 1 week and again it vanished away. And then we put her on another immunosuppressant as a thioprin, I believe it's called in English. And since then, she is symptom-free with respect to these symptoms. Now, this is a classical primary psychiatric case presentation of an autoimmune disease of which we don't know the precise pathomechanism, but still it's very important because the therapy is rather convincing. And the way forward, that's my final slide or second last slide, in this area is case-based. I think that's very interesting. Experts, you cannot kind of organize cohort studies, which is the traditional approach in research, that you compare big groups of patients with and without specific symptoms or with and without specific therapies. But in this area, as well in neurology as also in psychiatry, the whole progress is rather case-based, which I personally like very much. So, coming to my conclusion, secondary organic neuropsychiatric disorders are a small but a relevant subgroup of mental disorders. They generally present with a typical organic flavor or phenotype, but they may present, as in the second case, like classical psychiatric disorders, in this case like schizophrenia. It may look mental, but it could be the brain, to put it into a phrase, and investigations such as MRI, EEG, CSF, laboratory findings, and PET may be very helpful, but not always tell you the precise diagnosis neither, like in the first case. And there is a lot to learn and great potential in this area of medicine for our patients. Thank you very much for your attention.
It's really the oldest part of the human brain. And if you want to understand it, please think about traveling to Chennai on a train. You're coming to Madras Central, and in Basin Bridge, you wake up in the morning to a smell. It's not a very pleasant smell, but it makes you happy because you know you're close to home, right? And that's the same part of the brain that the rat shares with you, which is why the rat has a very good smell memory, right? So this is the oldest part of the human brain. It's not just a series of pathways, it's an extremely chemical-rich part of the human brain. And this gets affected as we get older, and that's something for all of us to keep in mind. Now, what happens also is that you have problems with blood flow and glucose metabolism. And I'll show you a picture in a short while, and that affects, your brain. You also have a problem in the neurochemistry. There is a decline in the dopamine transporter system. Right? So this is the reason why, as you age, you not only have problems with memory and cognition, as we call higher brain function, you also have physical problems with movement, motor functioning. And of course, at an extreme, that's what causes things like Parkinson's disease. But both these things are part of the aging process. Now the hippocampus is a part of your brain that's critical to your memory. So if you draw a line between your ears, right in the middle is your hippocampus. It's just the size of a finger joint, but yet it stores your entire life's memory. And how does it store it? It stores it like you would store files in an office, in sequential order, which is why when you're affected by a degenerative disease of your brain, you lose your newest memories first and you retain your oldest memories. So people, for example, forget the grandchildren in the family, then the sons-in-law and daughters-in-law, because they came later into the family, then the children, then the spouse, then the siblings, then the parents. And one reason why dementia is called a fate worse than death is that finally you forget who you are. You lose your own identity as a human being, and nothing could be worse than that for anyone. So that's the kind of progression that happens when it gets to memory loss. This is again a PET scan image, and what I want to show you is that if you see in the images below with the arrows, you can see how there is hypometabolism. And this is what you will see in a person whose brain is aging, in a person who's developing dementia. And that's something that we need to understand. And that's, of course, what we were talking about, the cerebral metabolism. What happens also as you get older? Picture this. A young person's going to the airport to board a flight. They get delayed. They land up late in the airport, and someone says, "Oh, gate is closed, sir. You can't get in." Or, "Gate is closed, madam. You can't get in." A young person immediately starts thinking, "Can I get another flight? Can I go and catch a train? Can I go get a bus? How do I get there?" Older people stand there and get terribly upset and annoyed, right? And one of the reasons for this is as you get older, you have a difficulty or an inability to shift set. You're not able to move from one train track that you're on mentally to another train track. It becomes it's harder and harder for people. The other thing that happens as you age is that it's your short-term memory that is primarily affected. Your long-term memory, your memory of how to do things, for example, how to ride a bicycle or how to drive a car, those things are retained, but your short-term memory goes. So you'll be often meet people, if you ask them, "What did you have for breakfast this morning?" they will struggle to tell you what they had for breakfast this morning. But if you ask them about something, from the past, they will give you all details. "Oh, I went to see this MGR movie, it was with my wife, and we had just been married." I can tell you the whole story because that comes from the past. So that's another feature of getting older. There is something called the concept of working memory. And the working memory is really what we call the executive brain. It helps you plan, it helps you organize, it helps you complete the round of tasks that you want to do. It helps you do it in a sequence that is appropriate. You will have a meal waiting for you when we finish this meeting, right? It's your working memory that tells you start with the starters, then go to the main course, and finally go to the dessert. If your working memory is not working very well, you will kind of mishmash it and not really follow any particular plan. So that's what your working memory is all about. And that gets affected as you get older. Okay. So there is a loss of efficiency in acquiring cognitive or higher mental function information. There is a problem with processing speed. You'll notice as we get older, we take time to absorb things. We take more time to respond to a question or respond to something. We slow down. And that's part and parcel of cognitive aging. All your old information, as I said, is spared. There's one point I want to make, because especially in middle age, I get people coming to me, oh, I'm really worried about my memory. And the point I want to make is the most common reason why you have subjective forgetfulness, I'm losing my memory, is being stressed out or depressed. It's not losing your memory. Okay? This changes as you get older, but this is very true in the middle years. So one of the things to always ask yourself when somebody says, I'm losing my memory, is to find out whether they actually are experiencing symptoms of stress, anxiety, or depression, or something else that's going on. Now, one of the other factors that we have to understand is that there is a transitional period. And this transitional period from normal aging, what used to be called in the old days benign senescent forgetfulness, to mild cognitive impairment, to dementia, frank dementia. The mild cognitive, The mild cognitive impairment is the time when you can treat. Because people don't come to you and say, I'm normal, can you treat me? People come to you when they start having a problem. And MCI is a very critical time for us to treat. And that's something, so early diagnosis becomes very important. And in this context, going through memory tests as part of a master health check, for example, is very important. Now, why do we have problems with aging? We often meet people who, post-retirement, there's a sudden drop in their cognitive functioning, and that is disuse. So I got my watch, I gave my 40 years of service, I had a nice retirement party, I went home. And from the next day, all I'm doing is reading the newspaper, going for walks. I'm not doing anything very active with my brain anymore. That can cause cognitive aging. One of the other things are little strokes, and I'm going to talk about that. As the blood supply gets worse, you have small strokes in your brain. They are not large enough to cause you alarm. They don't give you things like hemiparesis. But what they do is that they cut off little wires in your brain. And those circuits are important to you. And that's one of the reasons why you cognitively age. And the third, of course, is the degeneration, the pathological aging that we are talking about. Now, here is a picture, an MRI of somebody who is having multiple strokes in their brain. And this white that you see around the ventricles, the dark bags in your brain, the white that you see should not really be there. The white is a sign of poor perfusion. It's called leukoariosis. And if you have poor blood perfusion, then you have what we call lacunar infarcts, which are little strokes. And these have the impact of cognitively slowing you down. But today we understand it's not just cognitive impairment. They cause Parkinsonism. So people with vascular Parkinsonism walk with a very small stepped gait. The French call it marcher à petit pas. It's almost magnetic. It's almost like my feet are stuck to the ground. And late life depression is very strongly associated with poor blood supply in the brain. So we often attribute late life depression to psychosocial factors like loneliness and losing people in your life and so on. But this is the underlying biology for many people, that they have poor blood supply in their brain, and that's what's causing them to get depressed. So what underlies cognitive aging? On the one hand, you have the hold factors: hypertension, obesity, lipids or high cholesterol, diabetes. All these are preventable. All these advancing cause you problems. On the other hand, you have factors which are lifestyle factors: sleep, exercise, diet, and mental health. All these also are preventable, but this prevention starts earlier. right? So in some ways, most of us when we are 40 or 45, that's when we think about starting to walk, right? Or starting to exercise regularly. I meet a lot of young people today who exercise regularly from the time they're in their teens, and they are doing the right thing, okay? So the earlier you start to live a good lifestyle in terms of diet and exercise and sleep, the more protected you are from cognitive aging. So those are preventive factors too. In the middle, the colorful pictures are the pathology that happens in dementia. To put it very simply, waste product deposits itself in our brains. There's amyloid and tau. And neuroscientists have spent years fighting with each other as to which is more important. And today we know they are both important. They're both important in different ways. They both influence each other. But we know something else today. These risk factors, hypertension, obesity, diabetes, high cholesterol, we thought they only had something to do with the circulation and therefore heart health and strokes. Today we know they are also responsible for the amyloid and the tau. Okay, so in a sense, all this is interlinked. And it's all like a cascade that's waiting to happen. And when that cascade sets in, that's when you advance from normal cognitive aging to mild cognitive impairment and finally dementia. And that's the understanding that today we have about brain aging. Dementia is an extremely important condition because we're going to have an epidemic of it. You know, we talk about ourselves as the world capital of diabetes. I can tell you we're not far from being the world capital of dementia. There's only one reason, right? We have a large population, and that large population is starting to live longer and longer. And dementia is a disease of age. The longer you live, the more likely you are to experience dementia. So this is something that all of us need to keep in mind. We have, as per estimates, about 5 million people with dementia living in India today, and that number will probably go up to 7 million in the not so distant future. You can imagine the public health need, you can imagine the clinical need, you can imagine the disability needs. They are extremely considerable. It's not normal aging, and that's something that's very, very important. You know, we have this thing in society, oh, he's become old, and that's why he's become forgetful. Dementia is not normal aging because dementia causes disability. You can't do the things that you could do before, and progressively you need more and more help in order to get through your normal day. And as dementia progresses, people need to be led to the bathroom, people need to be assisted in their everyday ablutions, people need to be fed, people need to be kept safe, people need to be prevented from wandering from their house. It's a lot of stress on the caregiver. And there's something else that's happening in India. The caregivers, which are the families, are disappearing. How many people do you meet who are living in an extended family who are able to care for somebody with dementia today in urban India? Difficult. And if you look at people who are middle-aged like myself, I don't know who will be there to care for me if I get dementia, right? So this is a challenge that we are not addressing, and that's one of the reasons it's a scary epidemic, because the needs are going to be so great. These are global trends, and what I'd like to emphasize here is that deaths are affected. The blue line is India, and you can see it is always growing. Okay, so deaths are affected. Your disability adjusted life years, which are an index of how long you will live with disability, those are increasing. Prevalence is growing, and you know, if you think about it, the demography of India is changing, and with that, the problem of dementia and the associated issues are growing. The problem of brain aging is growing. We've had studies in all these places. Very happy to say that Chennai was something that we did many, many years ago. Both urban and rural populations are affected by dementia. This is something that we have to understand. And The other thing that we have to understand is that the causality is multifactorial. The good news is what I was telling you about the hold factors and the lifestyle factors. Dementia is preventable. Okay? So dementia is real. It's a disease. It's not normal aging, but it is preventable. And this is something that we all need to keep in mind. Now, here's another very interesting fact. As you get older, see how many disorders you gain. So it's not just wealth that you might gain, not just weight that you might gain. You gain what we call multi-morbidity. The number of disorders you have, the number of diagnoses you have go higher and higher. And by the time you're at 85 plus, you have 8 diagnoses on average. Okay? So the healthcare needs of the elderly are considerable because of this multi-morbidity. It's not just dementia that I'll have. I might have Parkinson's along with it. I might have stroke along with it. I might have arthritis along with it. I might have digestive issues along with it. In fact, most people I know who are older have problems with digestion. I may have urogenital issues along with it. I might have peripheral issues, skin and neuropathy along with it. So in a sense, the needs keep climbing as you get older. The number of diagnoses you have keep climbing also as you get older. And so pretty much every bodily system in some way will get affected as you get older. And this is something that we have to keep in mind. I'm going to get all of you to do a simple exercise to see whether your brain is aging or not. Okay? Put your hands out. Make a fist. Open your palm. Turn it to the side. Now repeat after me. Fist. Say fist. Palm, side. Now let's do this together. Fist, palm, side. Fist, palm, side. Fist, palm, side. Fist, palm, side. Now who was struggling? If you struggled, right, then that's a sign of your brain executive not doing very, very well. And who described this? This gentleman called Luria. Now there's another very interesting thing that he said. Okay? He said that this part of your brain is for regulating tone. This part of your brain to analyze and store information, and this part of your brain, the frontal lobes, for programming, regulation, and verification of activity. Now, what he was trying to say was, you know what you share with the rat, that's where your emotions come from. They are pretty primal. Okay? The front of the brain, which actually is huge, the frontal lobes, this is your decision maker. That's your executive. Okay? If you have emotional discontrol as you age, it's either because your emotional brain, which you share with the rat, has become overactive and this cannot control it anymore, or this has become weak and even normal emotions it cannot control anymore. All right? So, in a sense, your brain works in circuits, and even emotions and the regulation of emotions are governed by how different parts of the brain are working. And why am I saying this? These mechanisms also weaken as we age. How many of you have an older person in the family who sometimes says the most unacceptable things in company in front of everybody else? The point is that that's because that decision-making process is not working anymore the way it should work. I probably shouldn't say this, right? This is not the right time to talk to this person, whatever. That is what weakens as we get older, right? The emotion to say something may come, the regulation is weak. Or just normal emotions come, the regulation is weak. So this is something that we all have to keep in mind. So what impacts our mental health? A very large proportion of older people have poor mental health as they age. Physical health starts to fail. Okay? You're forced to adapt. The world around you is changing and you don't like the way it's changing. That causes you problems. Your social environment is changing. You become lonely because the near and dear are departing, starting to go. COVID taught us that. So many people lost people who were close to them during COVID. Insecurities start to creep in. Sometimes they are physical insecurity, sometimes they are material, sometimes they are psycho-spiritual. Okay? I've had older people ask me repeatedly, what will happen when I die? It's a thought that comes to your mind as you get older. So these are things that happen, and then of course memories become less sharp and less relevant. So an older person has many reasons why their mental health may get compromised. And that's something we need to understand, apart from the biological reasons we were just talking about. So what can you do? You can stay fit, okay? I think this is Canada. They have a National Senior Health and Fitness Day, okay? You can eat healthy. And if you Google online, you'll find many healthy eating pyramids. The pyramid is, things at the bottom of the pyramid are healthy stuff like fruit and vegetables that you eat every day or 5 to 6 days a week. Things at the top of the pyramid are things that are unhealthy for you, that you restrict to 2 or 3 times a week. You can find this online. The best diet for older people is what's called the MIND diet. Okay? And this comes from the Mediterranean diet, but I want to make one point here. The people who researched Mediterranean diets did not take one factor into consideration. They are consumed in salubrious surroundings, in company over 3 or 4 hours. So eating a Mediterranean diet like that and running to work in 10 minutes is probably not going to protect your brain. You'll have to not just eat the Mediterranean diet, you'll have to live the way people in the Mediterranean regions do in order to protect your brain. And that's something that most of us find very difficult to do in a country like ours. Okay? So, all we've had till now are drugs that influence neurotransmitters. And today, if you go to a hospital with dementia, what you're getting is this. We have non-pharmacological therapies. And that's a whole list. There are several things. There is emerging evidence that non-pharmacological therapy is very useful for brain aging and disorders of brain aging, which means that drugs alone are not good enough. You need rehabilitation, you need non-pharmacological therapies. You could do yoga, you could do Tai Chi, you could do what's called reminiscence. There are many things that you could do. Today we have a very exciting world of neuromodulation that's developing. And neuromodulation has great potential, stimulating your brain using a strong magnetic impulse or an electrical impulse, or even giving yourself oxygen. These are things that actually can improve your brain function. So there is emerging evidence and a lot of interest there. But finally, that's the article that came out in the Hindu in which I collaborated a few days ago. There are new biologicals. And what do? They address antibodies. Okay? And in a sense, if you think about it, they are trying to eliminate the waste products that have got deposited in your brain in excess. And that's the most exciting thing that's happened in dementia care. There was one called aducanumab. It did not show such a great effect despite accelerated approval, but we have lecanemab, which today is being looked at with a great deal of positivism. So these are new treatments. There's a different way of treating, and it's a little more in line with what Professor Ludger was talking about rather than many of the other therapies that we've been doing till now. What Dr. Rohini was saying, we have a Gothic clinic philosophy. Medical care, especially for vulnerable populations like disabled children with developmental disorders, elderly with neurodegenerative disorders, it has to be in harmony. I don't believe it's an either-or approach that's going to work. It's a multidisciplinary, multi-component, holistic approach that is going to help people with disorders of aging, but also right across the lifespan, people with any form of chronic disease. And so I'd like to stop by encouraging all of us to open our minds to aging, to dementia, to the possibility of multidisciplinary and holistic care. And finally, and most importantly, because we are hosting the Neuropsychiatry Roundtable, to neuropsychiatry as a specialty. This borderland between neurology and psychiatry is actually not small. It's very large. And there is going to be a time when all these disorders will need this kind of integrated thinking and approach that we've been talking about right through today. With that, I'll say thank you very much. Thank you.